They asked me to bring her in for today, but unfortunately, it's Mama's birthday today, so we had some other stuff going on. But anywho, any questions on stuff we covered last time? So you guys are all experts on how to treat rheumatoid arthritis, right?
Oh yeah. If we had questions, we are not.
Methotrexate for everyone, right? For the most part, yeah. A lot of people should get methotrexate. What else should you use? A TNF inhibitor? Maybe for some people, maybe they don't respond well to methotrexate. What else should you do in addition to, say, like, how about for symptomatic management? NSAIDs are good. NSAIDs are good options, right? What's a good NSAID for someone who has like a history of gastric issues? Celecoxib is a good one. Meloxicam might be okay. It's got some selectivity. What else can you use in conjunction with those? You get cardio stuff. You can't get cardio stuff, potentially, but not a huge amount of risk. But that's why, yeah, so you worry about high-risk kind of cardiovascular patients if you use a COX-2 selective inhibitor. But corticosteroids can be used as well, right? So it's one of the kind of few times where you may see patients using kind of long-term corticosteroids, usually as low dose as you can, right? Because of the side effects associated with that. Good. Okay. So then we talked about osteoarthritis and kind of how does treatment differ between rheumatoid and osteo?
There's no immune response.
Yeah, there's not really an immune response. There's inflammation happening, right? But it's more kind of a mechanical kind of inflammation. Yeah, so you use DMARDs to use those disease-modifying anti-rheumatic drugs for RA, but we don't really have anything like that for osteoarthritis, unfortunately, right? So that's kind of the big difference here, and so we're really just dealing with more symptomatic management for the most part, more than anything else. And so, again, using stepwise approach to kind of dealing with these patients and managing their pain, here's some kind of sample algorithms that you can kind of go to kind of guide you on what type of therapy to use. And it really depends on what type of symptoms are manifesting, right? So is it mainly in the hands where they're having symptoms of OA? Is it mainly in the knees or the hips? And so the treatment kind of differs a little bit based on that. But for instance, you know, the first stop should always be acetaminophen if you can. Who might be some patients you would not want to use that in?
Drinkers.
Yep, so maybe chronic alcoholics who have history of liver disease would be the big thing, right? So you can still use some acetaminophen then, but you may need to drop your dose to make sure, you know, and do some extra monitoring to make sure they don't have any evidence of hepatotoxicity. Okay, but if you can, you know, that's a good thing to try first. If not possible, then you can always try to go things like topical NSAIDs. That's going to be better for the knee specifically, just because it's kind of easier to get to that site of action versus the hips being a little bit deeper. The topical NSAIDs might not work super well for that. And then you can look at using things like the intra-articular corticosteroids, right? So, and how often can you use those? And 3 times a year, right? And so again, the effects, they last that entire period between injections? No, they're going to wear off, right? So again, this is really just kind of a, you know, just for symptomatic management. Really, if you're going to have like a really bad flare-up or something, that might be a good option there. Yes?
OA, I'm not OA. RA, would we use topical analgesics as well?
You don't see a ton of benefit from those, like, because really a lot of that inflammation is happening like within the joint itself. So like a topical like NSAID is not really going to have as much oomph as you want to really kind of deal with that inflammation. So you don't see a ton of those being used. Yeah. We mentioned tramadol in here. What type of drug is that? All that, you know, trying to pull back the cobwebs and those rusty file cabinets, right? All right, so it's a kind of a partial opioid agonist, right? So it's not kind of a full opioid, but it can kind of tickle those receptors a little bit to get some additional analgesia from there. And right, traditionally you see tramadol mixed with what other medication? Acetaminophen, right? So you have Ultraset, and then you have tramadol itself. So those are kind of 2 different varieties you might see, so you could see it in conjunction with the acetaminophen. So that could be possible. And then obviously the oral NSAIDs, younger patients are going to be better for that, especially with using systemic NSAIDs. What other kind of organ toxicity do you want to watch for? Yeah, you wouldn't want, so especially for patients who have kind of history of renal disease, if you kind of you have a kind of a temporary hit on that renal function for those patients, so be watching out for that as well. Good. And then if kind of everything else is failing, then we can move down to using things like more chronic opioids, which obviously we want to spare them as much as possible. But in a lot of cases, other things are not going to be working, and you have to use for those chronic patients, right? So topical fentanyl is a good option for kind of long-acting medications. Hydrocodone, oxycodone, also kind of oral options are all going to be potentially effective here. And then obviously the surgery is going to be the best thing. So if you can just replace the joint and make them part cyborg, that might be a good option as well, right? So there's some thought that you can use some duloxetine. Do you guys remember what type of drug that is?
Also SNRI.
Mm-hmm. This is SNRI, so selective norepinephrine reuptake inhibitor. Maybe some thought that it can help with some knee osteoarthritis, but I don't see that used a ton. But if they're having any kind of neuropathic pains in conjunction with this, then that could be something that could be useful as well, right? Because again, if you think about like an osteoarthritis, like a knee osteoarthritis, like what type of patient are you thinking about? So older patients,
Blue-collar worker.
maybe some blue-collar worker. Who's putting more stress on their joints than others? Yeah, obese patients who might also have diabetes, right? So they have neuropathies anyway. So you maybe can get some, additional bang for your buck by kind of treating multiple things at one time. So again, always try to look to where you can kind of minimize meds as much as possible. Okay. For hand osteoarthritis, you're going to be looking to see more kind of topical use, especially if they have any kind of contraindications to receiving systemic therapy. So you can get more use out of things like topical capsaicin. We talked about that quite a bit previously. And again, because they're applying it to the hands, like they need to watch out, kind of any mucous membranes are coming into contact with, because it's going to be pretty spicy. Other than that, though, the treatment is going to be very, very similar. Again, just going by a stepwise approach, using, you can still use intra-articular steroids here as well, which can be pretty effective for them. And obviously, there's not really a joint replacement you can do very easily for them. Otherwise, they'd have like robot hands and look like Anakin Skywalker or something. It doesn't really work that well. So maybe one day. Okay. So any questions on osteoarthritis? All right. So moving on, we'll talk about osteoporosis and osteomalacia. So we know this is a bone disorder characterized by kind of low bone density and this kind of impaired bone architecture, and you have kind of this compromised strength of the bone here. So big issue here. And again, what type of patients are we most worried about with this? Yeah, postmenopausal women are typically the big ones that you're worried about. Certainly men can still experience this as well as they get older. The big thing we worry about is the predisposition for fractures, especially like vertebral fractures, hip fractures, because what's that going to do to the patient following that? Increased mortality, right? So big increase for mortality, decreased quality of life, decreased activities of daily living because they're not as mobile anymore. So lots of problems with this. So if we can try to, you'll find that especially with osteoporosis, prevention is kind of the best thing you can do. Try to maintain good bone strength, but you'll see that it won't always be possible. So don't memorize this whole list of things that can be associated with osteoporosis. I highlighted just a few of the ones that are probably a little more germane to our discussions here in your clinical practice. But certainly anything that's inhibiting the effects of estrogen or anti-estrogen effects are going to decrease bone strength, right, and bone density. So that's when you see things like aromatase inhibitors. You guys remember what aromatase does? Turns things into estrogen, right? So you can convert things like testosterone over into estrogen. So if you block that, if you prevent aromatase from working, you have less estrogens, right? So that would make sense why you'd see, increased risk for osteoporosis with a drug like that. And that may be necessary for some patients who have, say, like really refractory to treatment breast cancer or something, right? Where you don't want any kind of estrogen effects on that breast tissue. We got around this in a lot of cases by using what type of drugs? Yeah, you guys remember the SERMs, the selective estrogen receptor modulators, where you can have something like raloxifene, which would have antagonist effects in the breast tissue, but it would have agonist effects in the bone. So those kind of products are going to be a bit more preferred in those kind of those type patients, mainly because they're still going to have good effects on the bone while still preventing the estrogen effects elsewhere. Okay. Obviously, things like glucocorticoids, long-term effects, this can be problematic. So just talking about rheumatoid arthritis patients, they're going to be a bigger risk for this, right? Especially if they're on chronic use of these oral corticosteroids, this is going to be a big risk for them. And then why do you think proton pump inhibitors with long-term therapy fall in this category?
Calcium absorption.
Good. So why is calcium absorption impaired? So calcium is absorbed in what type of medium? Acidic or basic? acidic, right? So if I'm chronically giving someone a proton pump inhibitor and I'm increasing the pH of the gastric fluids, they're going to impair absorption of calcium, right? So that's going to be one problem you can see with that, especially with long-term use of those. So just be aware, there's lots of other drugs that can affect this as well. Things like thyroid hormones, excessive supplementation can do this, but really I just kind of put these here just for kind of representative examples. Why do you think furosemide would lead to osteoporosis? Yeah, increased elimination of calcium. So if you're peeing out all your calcium, it's not there to be put in your bones, right? So you can kind of rationalize out some of these and just their mechanism of action. So kind of think about those things. Okay, so we know we're having this kind of delicate balance between bone resorption, which is being done by the osteoclast, so that's what's taking up calcium out of the bone, and then we have the bone formation, which is going to be regulated through the osteoblast. And so if we don't have a good balance between this, if we have too much osteoclast activity, that's where we run into problems with having too much bone demineralization and decreased stability of the bone itself. Obviously, a lot of different hormones are going to be affecting this, with estrogen probably being one of the most common ones. Testosterone is going to have positive or negative effects on bone strength. Well, positive effects, right? So testosterone is an anabolic steroid, and kind of think about that as being something that can add to extra strength to the bone. And then we have PTH, otherwise known as parathyroid hormone. And what does that do to the bone? It increases resorption of the bone. So we're going to increase osteoclast activity when you have excess PTH activity. And so what kind of things stimulate PTH to increase? Yeah, so low serum calcium levels, low vitamin D levels will also increase the amount of PTH that your parathyroids are kicking out, right? So a lot of the therapy we're going to be looking at to treat that is going to be centered around decreasing the activity of PTH, right? So if we can decrease PTH activity, you're going to have less bone being resorbed. You're going to be better off in the end. So that's going to be an important point we're going to look at here. So we mentioned the calcium homeostasis is maintained primarily by vitamin D and PTH. So if you have high levels of vitamin D, if you have high levels of PTH, that's going to be increasing absorption of calcium from the GI tract, and it's also going to be affecting resorption of calcium within the kidneys themselves. Okay. When we cover the nephrology section, we'll talk more about this. When you can have renal osteodystrophy that can occur, and a lot of that's going to be a big imbalance here between PTH, vitamin D, and calcium homeostasis. You're going to see some problems with that, but we'll talk more about that later. The important point here is that vitamin D, when you take, say, normal like choline or ergocalciferol through, like, say, a multivitamin, is that the active form of vitamin D? Nope, it's not active, right? So where does vitamin D get activated? So kidneys is one spot. Where else? We started to develop some precursors in the skin, for sure. That's where our sunlight's really good. That's why. Where do you go after the GI tract?
The liver.
The liver, absolutely. So there's kind of a two-step process here where you need to get this 1,25 dihydroxy vitamin D. This is a product called calcitriol, and so the initial step is where you can have choline or ergocalciferol taken through the diet. You can have some vitamin D precursors made through the skin. The first step of hydroxylation has to occur within the liver. Okay. Once that occurs, then it goes and gets the second hydroxyl group from the kidneys. So, for instance, if you had a patient who had bad kidneys, they're not going to be able to make the active form of vitamin D, which kind of sets off that kind of cascade where they're not able to really regulate their calcium levels very well. So that's why it's important to make sure that when you're looking at your patients and you're trying to supplement them with vitamin D, you need to give them the right product. Okay, so if they have a history of liver disease, they're not going to be able to do that first step of activation. If they have kidney disease, they're not going to be able to do that last step. Okay, so we'll look at the different vitamin D products and how we should be supplementing our patients. But that's a very important point to consider. Low calcium levels as well are going to stimulate the parathyroid to release parathyroid hormone, and that's going to stimulate that bone resorption. Stimulates calcium resorption in the kidneys, and then also is going to increase that osteoclast activity. So that's the main thing we're going to be focusing on, the thing we would like to stop from happening for our patients. And then also estrogen deficiency, so especially in postmenopausal women, that's going to be leading to more activity there as well. So prevention obviously is going to be our primary goal. This is why we do lots of good screenings with our scans and whatnot to make sure patients are not having decreased bone mineralization. Once the low bone mass kind of develops, the key point there is to help make sure we can stabilize and improve bone mass and strength, and then prevent any fractures from occurring. So ideally, the fracture prevention is going to be the biggest thing here, because the mortality risk is just so high afterwards once they do have a vertebral break or a hip break. Once a fracture does occur, then obviously you want to improve any pain, which we've talked about pain previously, any deformity that might happen there, and then make sure we're keeping their functional capacity and their quality of life pretty good, and then prevent any future falls/fractures. So as far as non-pharmacologic therapy, this is more kind of like dietary in nature, I guess. You want to make sure we're supplementing with good amounts of calcium and vitamin D. So this is going to be the best step for prevention for our patients. So calcium usually is going to be given as the carbonate form. So you can see calcium carbonate usually marketed as Tums. Certainly there's other forms that are out there as well. Usually anywhere between 1 gram to 1,200 milligrams is going to be recommended. You'll see different recommendations based on the age of your patient and male versus female, all sorts of things. But in general, it comes down to around 1 gram to 1.2 grams. Obviously, side effects associated with this is going to be constipation. Is going to be a big one. Right? Anytime you're giving extra calcium, you can kind of slow down the GI tract. Hypercalcemia is obviously kind of a secondary risk you might worry about, and then this nephrolithiasis. So again, kind of balancing out, specifically what your patient's past medical history is, what they're kind of at risk for, but making sure they need to still get their calcium supplementation. Other things to worry about is drug interactions where calcium can be bound to other things like iron, thyroid supplements, fluoroquinolones. You guys have heard all this before. Just make sure you're separating these things out by an hour or two, right? So either take the calcium 1 hour before or say 2 hours after the other medications that could bind it up, okay? And then vitamin D. Usually this will be given orally as either ergo or cholecalciferol. Cholecalciferol being vitamin D3, ergo being vitamin D2. That's probably the most common forms you're going to be seeing being given. A lot of people need excess or exogenous supplementation. Most people don't just hang out in the sun long enough to actually get enough vitamin D being made, right? So most people are going to need some kind of extra vitamin D intake. So once that gets into the system, that's when we get that first hydroxylation occur, and that's a product called calcifediol, and that's a step that is made in the liver. And then you're going to have calcitriol, which is the active forms made in the kidney, right? So if you have patients who have bad kidneys, am I going to give them ergocalciferol? Not going to do a whole lot, right? So you're just kind of, you can give it to them all you want, but it's not going to do anything, right? So I need to give them the active form. So for those patients, I can actually give them activated calcitriol already, and that way they can get absorbed orally and kind of do its mechanism of action. I don't have to worry about it being activated ever, okay? So consider what your patient's organ dysfunction is and make sure you're giving them the right kind of vitamin D product to be effective. So looking at the pharmacologic therapy, so again, medication is often going to be needed to treat or prevent osteoporosis in a lot of these patients. And then prescription therapy is going to be recommended for those postmenopausal women or men greater than 50 years if they have diagnosed osteoporosis based on scans and other things. The other things you're looking at is going to be their risk for fracture as well. So looking at if they have low bone mass and they have a 10-year probability of hip fractures of 3% or more, that would be indication for treatment. And then if they have a 10-year probability of any major osteoporosis-related fractures of 20% or more. So again, it's all kind of hedging your bets on who the most high-risk patients are and deciding if you want to be treating them or not. So we'll look at the anti-resorptive therapy. So this is going to be all the things to make sure we keep the calcium in the bone specifically where it's supposed to be. So we'll talk more about these in detail. All right, so the first one, we already talked about the calcium and the vitamin D, but the next thing we'll talk about are going to be the bisphosphonates. So the main ones we have here are going to be your alendronate, ibandronate, risedronate, and then zoledronic acid. These mimic an endogenous product called pyrophosphate that normally will be an endogenous kind of bone resorption inhibitor. So they naturally will inhibit osteoclast activity. These look very, very similar to that in structure, and so once they get into the bone, they can sit there, and you'll find that these drugs actually have a very, very long half-life. And so you actually see that how often you have to give these drugs is not, you don't use these drugs every single day. Some of them you can give years apart from one another between different doses. But by doing this, you're going to inhibit osteoclast maturation, the number of osteoclasts available, bone adhesion, and also the lifespan of the osteoclast. So these are all good things to make sure that the calcium stays in the bone where it's supposed to be. These drugs have really, really poor bioavailability, so usually less than 1%. So you'll find that drug administration education is going to be super, super important with this class of drugs. And if your patient cannot take these drugs orally, as they should, this is why we have to go with the IV option. Okay. So if you have any kind of concomitant food, beverages on board, you're going to lower the bioavailability even more. And so this is why you have to take the drug by itself with just like 8 ounces of water, and that's it, right? No other coffees, juices, foods, or anything like that, because you're just not going to absorb enough of the drug. So once the drug gets into the system, it gets incorporated into the bone. Any excess will be eliminated renally. And you find this biological half-life is up to 10 years, right? So when things get kind of stuck in the bone, they're there for a very long time until they just kind of get naturally processed out of it. That's also why if you have patients who have lead toxicity, that can have a very, very long half-life as well, because lead looks very similar to something like calcium and actually gets incorporated into the bones. That's why you see kids, when they get exposed to lead early on in life, especially if they're in like the inner city and they don't have good calcium and vitamin D supplementation, they get a lot of lead incorporated into their bones and can have some issues with that. So anything getting into the bone lasts a long time. So this is going to help us as well when we're looking at how often we have to give these drugs. Again, oral agents has to be taken correctly. I'll talk about the administration in just a second, but for any absorption for these drugs to occur. Mainly, the adverse effects you're going to see are going to be GI related, so you can see heartburn and dyspepsia. Sometimes these patients will have the tendency to have the pills actually stick in the esophagus, and so rarely you can see some esophageal erosion, ulceration that can occur, which can be problematic, obviously. And then there's also kind of a unique side effect where they have this osteonecrosis of the jaw that occurs. It's kind of a rare thing, but something to be on the lookout for. So again, make sure you're just taking this with water, no other types of fluids, and the patient has to remain upright for at least 30 minutes, right? So take it 30 minutes before any other food or liquid, and they have to be upright for 30 minutes. So based on the product, you can find that some of the drugs will be given weekly, monthly, or in the case of zoledronic acid, you may end up giving this yearly. So if you have a patient who's not really able, especially older patients who can't tolerate the oral products, this is where you go and use the IV products, right? So zoledronic acid is going to be the best thing for that. Get rid of a lot of the GI problems, and also the bioavailability is a lot better. So again, you'd have, like, say, a person go and get zoledronic acid on day 1, come in the next year, and then I think you can probably even space it out to 2 years apart. So that can be, it's more expensive, but it can be better off for your patient from a compliance standpoint. So next we have denosumab or Prolia. So this is a monoclonal antibody, as you can tell from the MAB suffix there. And so this one is going to be binding to this protein called RANKL, or RANKL. And basically it prevents RANKL from binding to this RANK receptor on the surface of these osteoclast precursor cells. So RANKL kind of stimulates and kind of kicks off this maturation process for the osteoclast. If you can prevent that from occurring, then the osteoclast never matures and never really does its thing. So this is another option if maybe patients were unable to use bisphosphonates for whatever reason. This might be another option here. This one is given by subcutaneous injection because, again, monoclonal antibodies cannot be given orally. And then you actually see it has a pretty long half-life here, around 25 days or so. So you can give the drug every 6 months, and so that also can kind of help with compliance. Other problems you can see, you can have some local dermatologic reactions with the injection site, some increased risk for infection, especially skin infections where you inject it, and then you can also have this bone turnover suppression that's occurring there, basically because the osteoclasts are important because they have that balance with the osteoblasts where they're kind of just turning over bone constantly. By suppressing that, again, the bone's just kind of staying right where it's at and not really getting turned over at all. Next, you have our mixed estrogen agonist antagonist, or the SERMs that we're talking about. Again, raloxifene or Evista is probably going to be the biggest one that we talked about because it does have those kind of positive effects on the bone itself. So this can be used for prevention of osteoporosis in women, especially those that are have a history of estrogen-dependent breast tumors and things like that. This could be a very good option for them. So it could be kind of added on to something like bisphosphonate therapy potentially. But again, you can go review those slides for specific side effects and other problems. Next up, we have Calcitonin. This is a product that is not currently recommended for osteoporosis, but it can be used in the cases of where nothing else is really working, or if the patient's not really able to tolerate anything else. This could be a good option. So Calcitonin is an endogenous product that we make ourselves. It's being released from the thyroid gland whenever calcium is elevated. You can kind of think about calcitonin as being kind of the natural antagonist to parathyroid hormone. It opposes all of those actions. So if we can give exogenous calcitonin, that can actually help to decrease the effects of PTH and decrease a lot of that increased osteoclast activity. So this one is actually produced, I don't know who discovered this, but it actually is a product that we gather from salmon sperm. Go figure. Also protamine that we get, protamine being a reversal agent for what anticoagulant? Do you remember? Not warfarin. Heparin, yeah. So you can use protamine for heparin. Protamine gets used in some insulin products. That actually comes from salmon sperm as well. So it's also a good fish to eat. So you also get some good drugs out of it. So it's a good fish overall, I think. Anywho, calcitonin has to be administered intranasally, so you can see some nasal sprays for that. And really, we don't see, as far as looking at the actual clinical effects of this in trials, it doesn't really have any good effects on hip fractures, but it appears to decrease risk for vertebral fractures. So this will always be used as maybe second, third line agent if they really can't tolerate anything else. Really, the bisphosphonates are your go-to because those do have proven track records for decreasing vertebral and hip fractures. So more often you'll sometimes see calcitonin being used in the cases of hypercalcemia. We'll talk a little bit more about that when we get to the endocrinology section. So next up we have Teriparatide or Forteo. This one is going to be for patients who have high risk for fractures, who have failed using bisphosphonate therapy. And you guys, how are we kind of monitoring for the effects of how good our bisphosphonates are working? So looking for fractures, that's a good one. Well, yeah, so doing bone scans and DEXA scans and things like that are able to tell us kind of, what's the progression here? Are we having any kind of reversal of the effects and having kind of increased mineralization of the bone? So again, you're going to be monitoring this throughout therapy. So if they fail bisphosphonate therapy, then sometimes teriparatide can be used. And this one's interesting because it actually has the first 34 amino acids of parathyroid hormone, and so it has kind of similar activities. So it's kind of tricking the parathyroid receptors into thinking that, hey, this is the same product. Really, it was meant to act as kind of an anabolic agent that stimulates bone formation, but because it's going to be stimulating those parathyroid receptors anyway, you're going to see increased osteoclast activity, but also as well, you're going to have increased osteoblast number and activity as well. So basically, you're just kind of trying to supercharge this kind of bone turnover process, and hopefully, you're going to have a net decrease in the osteoclast activity. So it's kind of an antagonistic kind of mechanism of action, but it could be useful for some patients. There is a REMS program. You guys remember REMS programs? For Accutane, stuff like that. So again, this one has a significant risk for causing bone cancer, just because you are kind of stimulating those type of cells kind of much more over what they would normally be. So they recommend taking for less than 2 years. Any longer than that, the risk for cancer, bone cancer, is going to go up. And so there are registries and things like that to try to protect patients. So essentially, when you are treating a patient with osteoporosis, it's all going to be based on the risk factors and kind of what the degree of demineralization has already occurred, essentially. So for instance, if your patient already has history of a fracture, oops, let's see. So if a patient already has history of a fracture, either vertebral or hip, then obviously, yes, they're going to need treatment for this, right? So you're obviously going to go down and look for any kind of secondary causes. Were there any medications that might have been involved? And then you're going to be doing things like adding calcium and vitamin D onto them. And this is where you want to jump into using your anti-resorptive therapy, right? So first line is always going to be your bisphosphonates. Denosumab is going to be, kind of a secondary one if they cannot tolerate the other guys. And then also looking at alternative therapy, things like raloxifene, teriparatide, all could be used potentially as well. And then really intranasal calcitonin is going to be kind of like your last line therapy if nothing else is really working. Okay, but for everyone else who does not already have one of these fractures, you're basically looking at to see, well, what's the extent of the damage that's already been done? Where do we need to can we just get away with using calcium and vitamin D, or do we need to kind of go a little bit more be a little bit more proactive and start to give more of this. So again, it's all looking at the risk of the patient and seeing, kind of what their risk factors are going to be and what their risk for fractures will be coming up. So again, if they're already having, say, osteoporosis or high fracture risk, you're also going to go ahead and just jump right into medication therapy. But for some, lower risk patients, they have normal bone mineral density, regular T-score, you can get away with using, calcium and vitamin D. So kind of take it all into account with your patient and make sure you're having those kind of conversations, especially with the bisphosphonates. Make sure they're able to tolerate it and they're able to be compliant with the medication. They can take it appropriately, because otherwise it's not going to do any good, right? So any questions on that? Yes.
How do you take Forteo?
Forteo, I believe it's an IV product.
Okay.
Double check on that one. You don't use it very often, or I don't see it being used very frequently, so yeah, didn't delve super deep in that. But really, the bisphosphonates are probably going to be your most your go-to gold standard for a majority of patients. All right. Move on, then we'll talk about gout, because there's really no other good place to talk about gout, so we'll talk about it here. Right. So have you guys covered gout at all yet?
Mm-hmm.
Okay, so it's like a rich person's disease. You guys know why that is? Used to be high protein, right? See these like kind of old school pictures of these guys that have like devils on their big toes with a pitchfork, and they're super rich and eat lots of meats and stuff. But anywho, so gout is going to be this kind of spectrum of diseases that includes hyperuricemia. You're going to have these recurrent kind of acute cases of arthritis with these monosodium urate crystals that accumulate in the synovial fluid and the leukocytes. So that's the main problem we're trying to deal with here. You can see these crystals kind of forming in other tissues as well, depending on just the degree of hyperuricemia and just if your patient's more predisposed to it. You can also see some renal disease as well associated with this, right? So especially looking at things like pH of the urine and things like that, that can all affect whether or not these crystals are going to be precipitating out and be problematic for your patient. So obviously uric acid is the problem here. So you get uric acid from the terminal degradation of purines, right? So purines and other waste products that are being degraded from these cells end up developing uric acid. I'll show you the picture of the process in a little bit. It's pretty complicated, but it's important because there are some drugs that are going to be important for interacting with this process. But basically, patients will have increased urate pools, are more likely to precipitate either due to overproduction of uric acid or they have under excretion from the kidneys. Okay. So if people have overproduction, they may have some enzyme abnormalities. They may have increased breakdown of nucleic acids. Can you guys think of any patients that might be like that? Psoriasis? I don't know. It wasn't what I was thinking. Yeah, cancer patients are specific. So one of the things you run into, especially with leukemic patients, is that when you give them large doses of chemotherapy and you wipe out a ton of those white cells, they start to lyse open and they start to release all these purines and whatnot. They get broken down into uric acid. And so we call that tumor lysis syndrome that you can see from that. So we'll talk about a drug specifically used to treat tumor lysis syndrome, but that is one thing you want to be looking out for. So if you see, like, especially me dealing with pediatric patients, see a young patient who's on chemotherapy and they're also on allopurinol, it's not because they get gout, it's because of the fact that they have a lot of purines that are being spilled out from these cells and they're producing more uric acid. Okay. So you can have that issue. You have excessive cell turnover, so you can mention with the myeloproliferative diseases that can be problematic as well. And then with underexcretion from the kidneys, could be idiopathic, or you could have dehydration being an issue here. So again, dehydration is going to kind of shrink your volume stores, make it more likely for those crystals to precipitate out. So our treatment goals are to terminate the acute attacks and try to prevent any kind of recurrent episodes if we can, and then try to prevent any long-term complications from these, kind of chronic deposition of these crystals. What do you call those depositions of crystals?
Tophi.
Yeah, the tophi, the tophus, which makes sense because it attacks the toe, right? So. And so the therapies we're going to be looking at are either going to be working as anti-inflammatories or they are going to be urate-lowering therapy. Okay. Those are two main modalities. So looking at the acute gouty attacks, as far as non-pharmacologic therapy goes, you can do things like apply ice to the site, but for the most part, going with drugs is going to be better in this case. So obviously we can use NSAIDs. You guys remember everything about NSAIDs, who to use COX-2 selective inhibitors in, and X, Y, and Z. Rarely do you need corticosteroids to deal with this inflammation. Usually the NSAIDs will be good for the most part. And then we have kind of an older drug called colchicine, which we'll talk a little bit more about in detail. Therapy should try to be begun as early as possible. So a lot of patients, especially if they have kind of acute recurrent gouty attacks, like they'll already have prescriptions for a lot of this stuff. So that way, once they have an attack start to hit, they can go ahead and start taking something for it. And then for patients who have kind of multiple joints being affected, or if they have more severe pain, combination therapy can be used in some cases. So we mentioned NSAIDs, we know all about those. The corticosteroids are going to have pretty similar efficacy as we would see with the NSAIDs. You can see some being used orally. Obviously, that has a little bit slower onset of action, but you can also use intra-articular injections as well. So probably the most common one that we use is going to be triamcinolone acetonide or Kinalog. That one can be used intra-articularly. If greater than 2 joints are being affected, then you're probably going to need systemic therapy, right? Because you don't want to be injecting corticosteroids in every single joint that gets affected. Especially with corticosteroids, if they are on it for greater than a week, then obviously you're going to need to include a taper with that. Okay. So the new drug here is going to be colchicine, otherwise known as Colchris. This is an antimitotic drug. So essentially what it's going to be doing, especially in rapidly dividing cells, it inhibits cell replication, right? Because mitosis is occurring when the cells are kind of pulling apart. This is actually affecting those microtubules that are kind of pulling the DNA into separate copies, right? And so in gout, what it's actually doing is by binding to those microtubule proteins in the neutrophils, it actually inhibits their migration, so they can't really get to the site of action to cause that inflammatory response where the actual crystal deposition is occurring. So, but a lot of the side effects are going to be related back to that antimitotic action as well. So we use this for acute gouty attacks, usually within 36 hours. If you kind of go beyond that, it kind of starts to lose efficacy. There's actually some new recommendations for using, there's actually a newer product that has a new brand named Colchris, and so they actually have some recommendations for prophylactic therapy. So you may see some patients being on chronic colchicine, whereas before, kind of the old dosing recommendations were you actually just give this drug until the patient throws up, and then that's like your max dose. So a really kind of archaic way of doing things previously. But that kind of goes along with the major side effects, which are GI in nature. Lots of nausea and vomiting associated with this drug, lots of diarrhea. And then with higher doses especially, you can end up seeing a lot of these, you see degradation of these cells. You can see neutropenia, obviously because the white cells are rapidly dividing, and you can actually see some neuromyopathies in addition to this. So it's not a great drug. I personally don't like it very much, especially with, like, if you ever see an overdose of colchicine, like that person's not going to do very well. Usually just wipes out their immune system and then they get a secondary infection and die from sepsis. Yes, no good. But can be used for some gouty patients if they don't respond to other stuff very well. So again, looking at just kind of the intensity of the pain, obviously if it's more severe pain, if it's a lot of joints being affected, you can start to consider using kind of multiple drugs at once. So like an NSAID plus colchicine, corticosteroids plus colchicine, whatever it happens to be. Those are kind of your options there. And most of your patients are going to have these recurrent attacks. You can kind of talk to them and see what's worked for them before, what hasn't worked, and kind of guide your therapy based on that. If it's just more mild to moderate pain, using a single drug is going to be better for those patients for the most part. For dealing with the hyperuricemias, we have some non-pharmacologic therapy for preventing those recurrent attacks. So obviously, that would be the best thing for them. You'd like to maintain lower uric acid levels. So one thing you can do is limit alcohol intake. See some purines there. And then also limit medications that are going to potentially raise uric acid. So things like thiazide or loop diuretics can cause some increased reabsorption of uric acid, can be problematic. Niacin, low-dose aspirin, all those things can potentially increase your uric acid levels. What kind of dietary changes would you want to do?
Less protein.
Less protein, which that's terrible. Who'd want to eat less protein, right? So I'll just take drugs for it instead. Some patients may think that, but yeah. So dietary changes would be ideal as well. As far as urate lowering therapy, the drugs we can give to do this, we'll find that this will be most effective for patients who are having kind of 2 or more attacks per year. Especially if they're having, obviously, the more frequent it is, the more benefit they might get out of this urate lowering therapy. Or it can also be considered if you have 1 or more of these, this tophus is present, if they have chronic kidney disease associated with this, or any history of urolithiasis. These are all going to be good options for these patients to kind of get rid of some of that uric acid. So the things we can do will either be decreasing the synthesis of uric acid. So if you never make it in the first place and keep it in more soluble forms, you can just pee those out and don't have a problem with it. Or we'll have drugs that actually are called uricosurics, which will actually increase the uric acid excretion. So this is the process for producing uric acid. As you can tell, I'm not going to get all super into detail on this, but the main point here is being you have this product called hypoxanthine that gets converted into xanthine and then finally into uric acid. And so the important enzyme here is the xanthine oxidase. It's kind of responsible for both of these steps. So obviously if you can inhibit this enzyme, you prevent that uric acid from being produced in the first place and hopefully less gout. Okay, you guys know the drug we're going to use to block that? Yeah, allopurinol is one. Does anyone know the other one? You're supposed to, right? You'll know in a second. So I mentioned these are xanthine oxidase inhibitors. So these are impairing that enzyme unless you produce less uric acid. These are going to be the most widely used options to prevent gouty attacks. You don't really see the uricosurics being used very frequently. But allopurinol is going to be a big one, and then febuxostat or Uloric is the other kind of newer one. For a long, long time, all we had was allopurinol. It's pretty cheap. You're probably going to see most patients being put on this. If this is not working for them, then they might be switched over to the Uloric instead. Allopurinol is pretty well tolerated for the most part, but you can see rare cases of some rash. You can see things like Stevens-Johnson's, toxic epidermal necrolysis. Those kind of rare skin conditions can be possible as well. But febuxostat, is pretty well tolerated as well. May see some arthralgia, some transaminitis, but for the most part, you don't see as many of the skin manifestations. And then you have the uricosuric drugs, so this will be probenecid is the big one. This is, again, another very kind of old agent. You will find that this works by inhibiting that kind of post-secretory renal tubular absorption of uric acid. So normally uric acid would be filtered through the glomerulus and then reabsorbed in the tubules. We're actually blocking that reabsorption from occurring there. Okay, so as you might imagine, if you increase the amount of uric acid within the renal tubules, what's going to happen? You're going to precipitate out and get this nephrolithiasis. So actually, this is why we end up using things like allopurinol much more frequently, just because you don't really run that risk of that occurring. As far as adverse reactions go, obviously precipitation of acute gouty arthritis can be problematic here, as well as some GI irritation, and it can actually end up increasing levels of other drugs like penicillins and cephalosporins. We actually used to use this for our benefit. So back in the day, before we had a lot of the newer penicillins out, this is like back when penicillins first generated, the half-life wasn't really long enough, and it was hard to actually make the product. And so we'd actually give probenecid along with that and actually prevent secretion of the penicillins into the urine, and so the patient's half-life would increase and keep the drug around for longer and treat those infections. So kind of a little historical pharmacokinetic interaction we use to our advantage. But patients who have renal impairment, you do not want to use probenecid for them. Would be contraindicated. And then one other drug I'll mention, this one is used primarily in the cases of treating tumor lysis syndrome for patients who have cancer and are having a lot of spillage of purines into the blood. This is actually a recombinant form of urate oxidase. So if you're looking at allopurinol, you kind of prevent the uric acid from being produced in the first place. This enzyme actually is recombinant, will go in and just break down the uric acid that's already produced. Okay, so once you produce the new uric acid, this enzyme can come along, cleave that, and we get into a more water-soluble form, and you just pee it right out. So it's a very, very expensive drug. We have very kind of strict criteria on what type of patients we're using this with. They have to reach a certain uric acid level. They have to reach certain criteria. If they have any renal dysfunction that occurs due to the hyperuricemia, those will all be good indications to use it. We don't like to use this drug a lot because you can actually end up seeing antibodies developed against it, and so it actually would decrease the efficacy of the drug over time. So really kind of sparingly use this one, and you can also run the risk of having methemoglobinemia and hemolysis if you had a patient who had a G6PD deficiency. Okay. So again, usually you're going to be looking at, does your patient have the indication for uric acid lowering therapy? If they have recurrent attacks, things like that, those are all going to be good indications. Obviously, the first thing you're going to kind of go with is going to be your xanthine oxidase inhibitors. So allopurinol, febuxostat are going to be kind of your go-to drugs initially. Obviously, you're going to have acute gouty attack meds as well that they're going to have kind of to be used as kind of an as-needed basis, whether it be NSAIDs or colchicine, whatever it happens to be. And then you're just kind of monitoring the uric acid levels and kind of seeing, okay, do we need to fix the diet? Do we need to kind of optimize our doses of the xanthine oxidase inhibitors, whatever it happens to be. And basically just with the goal of trying to prevent any of these attacks from occurring in the first place. So pretty straightforward as far as therapy goes. So any questions on that? All right, we'll go ahead and cut it early for today. You guys may go study or do whatever it is you wish to do with this extra hour, and we'll do peds on Tuesday.